The chairpersons for this session, Dr. Varun Mehta, Dr. Pankaj Gupta, Dr. Sanjay Khanna, and Dr. Sumit Rangta. Can I please request you to please chair this session on hepatoradiology rounds?
So the next session is hepatologists are from Mercury, radiologists are from Uranus. What do radiology reports really mean? And it's my proud privilege to invite Dr. Raju Sharma. And uh, thank you.
I'd like to thank the organizers for giving me this opportunity. I think this very provocative topic flows directly from Sanjay's session, which was very interesting. It kind of implies that radiologists and hepatologists are on different pages and don't agree. But if we see this tagline for a colorectal clinic from southern part of India, I think the radiologists would much prefer to be on some other planet, and the gastroenterologists and hepatologists would prefer to be on Uranus. Radiology reports are read by a number of stakeholders, and this kind of Venn diagram shows that it is very important that the terminology, the lexicon, and the language is standardized so that everyone speaks the same language. They need to be clear, consistent, concise, actionable communication of imaging study results. Reports can be of different types. There can be narrative reports, which the traditional radiologist was used to, writing paragraphs of prose. But I think increasingly they're being given up for most diseases, and we are switching to a more standardized and structured format. The structured report uses a template, a more of a yes, no kind of a situation for the radiologist, and then an impression at the end of the report. And there are now AI tools available which can also do the same for you. You can actually just speak sentences and paragraphs, and the software can convert it for you into a template. Before we delve into reporting per se, we also need to see that the technique that has been adopted is adequate. And typically, when we are talking of the liver, we do a multi-phase scan, do an arterial, venous, and a delayed phase, with the timings written here. And when we do an MR, we also do a hepatobiliary phase, which in the case of the contrast agent available in India, which is multi-hands, comes at about 1 hour from the injection. Just a schematic showing you, if I could have the lights down, maybe the images will project better. So we typically need a late arterial phase whenever we are evaluating a focal liver lesion where the liver parenchyma is not enhanced, the arteries and the portal vein are enhanced, and the background liver is not. The lesion, hypervascular lesion, enhances and then stands out against the hypovascular liver. In the portal venous phase, it's not just the portal vein, but the hepatic veins which are also enhanced, and now the lesion tends to wash out. The hypovascular lesions are better appreciated on this phase. And then there is a delayed phase, a typically equilibrium phase, where contrast washes out from both the liver and the lesion, except for some lesions like hemangiomas and mass-forming cholangiocarcinomas, which tend to retain contrast in the delayed phase of imaging. I'll spend a minute talking about the terminology that you will read in your reports. And typically, we use terms for the arterial phase and for the venous phase. There is something called rim arterial phase enhancement, where only the periphery of the lesion enhances. And then there is the typical arterial phase non-rim enhancement, which occurs throughout the substance of the tumor, can be homogeneous, can be heterogeneous, but is not only in the periphery. And this is what HCC shows, whereas rim enhancement is seen in mass-forming cholangiocarcinomas. And then there is, of course, a non-enhancing lesion like a cyst. In the venous phase, a lesion which is showing rim enhancement may become iso-intense or iso-dense on CT. It may wash out completely. The non-rim type of arterial phase enhancement may show washout, and the lesion may then appear hypovascular in the portal venous phase. On the other hand, lesions may retain contrast in the delayed phase, and these are the typical mass-forming cholangiocarcinomas. And because of this stepwise carcinogenesis from a large regenerative nodule to early HCC to overt HCC, we have an opportunity for detecting these lesions early in the course of disease. This is a busy slide, and I won't spend too much time on it, but just suffice to say that the regenerative nodules are hypointense on T1, hypointense on T2, and do not show enhancement after contrast. It is only the high-grade dysplastic nodule which may show some enhancement, and then it becomes very tricky to distinguish this from HCC. Let me show you some examples. These are multiple hypointense nodules studying the entire liver, and these are just regenerative nodules. The low-grade dysplastic nodules tend to be bright on T1, dark on T2, and do not show enhancement after gadolinium. It is the high-grade dysplastic nodule, which is hyperintense on T1, it's barely visible on T2, and may show arterial enhancement. Early HCC, on the other hand, may present with an enhancing nodule within the lesion, which has been called nodule within a nodule appearance, and this is how we distinguish the different nodules from an HCC. Just to show you the spectrum of a hypovascular lesion, a hypervascular lesion, and a non-enhancing lesion. So these are metastatic deposits in a non-cirrhotic liver, which are hypovascular. This is a typical small HCC, a hypervascular lesion, enhancing much greater than the background liver in the arterial phase. This is also an arterial phase, and there's a lesion seen here which does not enhance with contrast at all. The lexicon that we're going to talk of more now is the LIRAD nomenclature, because that has standardized the terms that we use for describing the focal liver lesions in cirrhotic livers or in those livers which are predisposed to developing HCC. So whenever you have cirrhosis or chronic active hepatitis or a current or prior HCC, we can apply this LIRAD nomenclature. We do not use it when the cause of cirrhosis is something like Budd-Chiari syndrome, chronic portal vein occlusions, and cardiac congestion. So how do we use LIRAD? The LIRAD categories reflect the probability of an observation being HCC and ranges from LR1, which is a definitely benign lesion, to LR5, which is a definitely HCC lesion. We first determine whether enhancement is present or not. If present, is it rim or non-rim? Then assess the size of the lesion. Is it less than 1? Is it 1 to 2? Or is it more than 2 centimeters? And finally, look for the additional major features of HCC, which include an enhancing capsule, non-peripheral washout, and a threshold growth of the lesion over the last 6 months. And I'll show you examples of all this as we go along. LIRAD is a good 50-page document. It's freely downloadable from the American College of Radiology site, and it's worthwhile going through this. This typically shows that there are different LR categories, and from 1 to 5, it basically increases your suspicion for HCC. There's a grid here. So LR1 is a definitely benign lesion. LR2 is a probably benign lesion. For LR3 to 5, we have this grid based on size, based on the presence of arterial phase enhancement, based on non-peripheral washout, enhancing capsule, and threshold growth. There are also some ancillary features that are described, which are left to the discretion of the radiologist, whether you want to use them or not. But increasingly, meta-analysis have shown that the ancillary features do not really increase the area under curve for LIRAD classification of liver lesions. So again, just a recap, this is the appearance of non-peripheral arterial phase hyperenhancement, where bulk of the lesion shows you enhancement. Non-peripheral washout, again, the entire lesion washes out, not just the periphery of the lesion. Capsule is the peripheral rim of enhancement, but it is seen in the more delayed phase. So this is different from the rim enhancement in the arterial phase because you see capsular enhancement in the delayed phase. Then the size of the lesion is important. And of course, threshold growth more than 50% in the last 6 months is a feature that is taken for HCC. And again, just to recap, definitely benign lesion is LR1, probably benign lesion LR2. And for the LR3 to 5 lesions, you have to use this grid based on size and the presence of arterial phase enhancement, along with these major features, which are capsule, washout, and threshold growth. These are the ancillary features. There's a long list. There's no need to remember this. The radiologist will do that for you. The important amongst these are the presence of T2 hyperintensity and restricted diffusion, which are features which go in favor of malignancy. You can upgrade an LR3 lesion to LR4 based on the presence of the features of malignancy, but you can never upgrade it to LR5 based only on the presence of ancillary lesions. The good part about LIRAD is that it sort of gives you management guidelines. LR1 can just be returned to normal surveillance for every 6 months. LR2, your surveillance may be at a shorter interval. LR3 again goes back to surveillance, but the interval for surveillance may be shorter than 6 months. You could do your repeat imaging at 3 months or use an alternate imaging, which means that if you've used a CT earlier, you should use an MR the next time. It is the LR4 lesion which goes to the MDT team for deciding what the further management should be. And it is this category where biopsy can play a definite role because the radiologist is telling you that he is not very sure, but has a high index of suspicion for HCC. whereas LR5 is the lesion which is fulfilling all the criteria and therefore can be taken up for treatment without biopsy. This category of LRM is a lesion which shows you features in favor of malignancy, but not necessarily HCC, which means it shows rim enhancement essentially. And you are considering the possibility of mass-forming cholangiocarcinoma or metastatic deposits, which are rather unusual in a cirrhotic liver. Therefore, in the LRM, biopsy becomes mandatory. Then there is the category LRTIV, which is tumor in vein. And here, the job of the radiologist is to distinguish a bland thrombus from a tumor thrombus, most important criteria being the presence of enhancement, a thread and streak kind of enhancement within the thrombus in the portal vein, diffusion restriction, and luminal distension. Those are the three features that we look for, calling something tumor in vein, and that is a separate LIRAD category, and again, may need a biopsy. This is the meta-analysis published recently in Radiology, which showed that ancillary features, which is a very long list, do not really add too much to the area under curve for LIRAD assignment. Let's look at some examples. Here's a lesion, very bright on T2, shows peripheral nodular enhancement on arterial phase, shows centripetal progression. If you have this constellation of findings, this is a hemangioma, an LR1 lesion, definitely benign, does not need any further management. Here's a lesion which is LR2. This is a cirrhosis-associated nodule, bright on T1, very dark on T2 because this is a cirrhotic nodule, almost no enhancement on post-GAD images. Small, less than 1 centimeter lesion, no washout. This is LR3, can be kept on surveillance but at a shorter interval of time. Again, about a centimeter-sized lesion, shows some peripheral washout but does not fulfill all the criteria for HCC. This would fall into LR4, which means there is a high index of suspicion for for a HCC, about 74%. Whereas a definite HCC is a lesion which shows you it's larger than 2 centimeters in size, shows a non-rim type of arterial phase enhancement, shows washout in the venous phase. When we say washout, we are comparing the lesion with the background liver. That's an important point to remember. I'm not comparing the lesion with the appearance on the arterial phase. I'm comparing this lesion with the background liver, and if it is darker than the background liver, it shows peripheral washout. And in the equilibrium or the delayed phase, if you see this thin rim in the periphery, that's the capsule. So this is a lesion which is a definite HCC and can be assigned an LR5 category, and our suspicion or the likelihood of this being HCC is 100%. So this is a schematic which basically shows you what is the percentage of HCC in lesions from LR1 to LR5. So LR1 is 0% HCC, then moves on to 16% in LR2, 37% in LR3, and LR5 finally is almost 95 to 100% HCC. So these are some more lesions. I'm going to skip some of these in the interest of time. I'll just show you the LRM category because that is very important. Here's a lesion which shows only peripheral rim enhancement. This is not the kind of enhancement you see in HCC typically. This rim enhancement suggests that you could be dealing with a mass-forming cholangiocarcinoma. The other features which help you are this capsular retraction. Remember, mass-forming cholangios are lesions which are fibrous with a fibrous matrix. That is why they cause this capsular retraction, and they retain contrast in the 1 hour delayed phase. So this is a hepatocyte phase of an MR scan. And if you see this kind of retention of contrast, this means that this matrix of this tumor is fibrous, and this is LRM, likely to be mass-forming cholangiocarcinoma. Again, just tells you that this index of suspicion for malignancy and for HCC goes up from LR1 to LR5 and LRM categories. Let's see some typical examples. Again, this is an arterial phase post-CAT image, shows you non-rim type of arterial phase enhancement. Notice that even the center of the lesion shows you enhancement, although it is somewhat heterogeneous. Then it washes out in the venous phase because it is now darker than the enhancing background liver. In the delayed images, you have a capsule. So all the major features for an HCC are fulfilled, and this is a this is a hepatocellular carcinoma. So detailed report of this would read where the lesion is, what is the size of the lesion, what are the criteria that it fulfills, assignment of a LIRAD category, which is LIRAD 5, and then a recommendation at the end. Given the LIRAD 5 classification, an MDT board discussion is recommended for treatment planning for this lesion, which is definitely an HCC. So prior to LIRAD, radiologists would write things like suspicious for a possible small HCC, and you really didn't know what is the index of suspicion, what is the likelihood, versus now where we follow and you get an ordinal number like LR5 lesion in the previous case that I just showed you, suggesting a definite HCC. So an ideal radiology report should have, firstly, the patient demographics, clinical history, what technique has been followed, comparative studies, if any, the key findings, which I have just talked about, an impression and also a recommendation whether the patient should go back to surveillance protocol or should go to an MDT for management discussion. The key findings would include the background liver morphology. When you're assessing the focal liver lesion, what is the T1 signal, the T2 signal, whether there is arterial phase enhancement, whether there is washout, delayed enhancement, capsule, diffusion restriction. Then we comment on the vascular structure. What is the status of the hepatic artery, the portal vein, the hepatic veins, the biliary tree, any associated findings like portal adenopathy, distant spread of disease. Assign a LIRAD category, explain its implication also if possible, and give a recommendation. So this is a template that the Radiology Society of North America offers. You give a number to the observation. We don't call them lesions in LIRAD. We call them observations because some of them may be pseudo lesions. So the term observation is preferred. Give it a number and then give it these specific criteria and features that I've been talking about: non-rim type of enhancement, threshold growth, washout, capsule, ancillary features, and overall assignment of a LIRAD category at the end. Radiologists are prone to using terms like consistent with, suspicious for, possible, less likely, unlikely. If you're following LIRAD in this situation, you can do away with these terms. However, when you're doing other reporting for other tumors in the rest of the abdomen, sometimes you do have to use these tumors. Then it's a good idea to attach this key in your report so that the hepatologist and the gastroenterologist understand what is your index of suspicion for that pathology. There are, of course, drawbacks in LIRAD. It doesn't tell you anything about prognosis, doesn't try and predict histology. We know that there are some specific features on imaging which can predict histology. For example, if you have a patient with very high alpha-fetoprotein values with large areas of necrosis within the tumor, then you can suggest that this may be a macrotrabecular massive HCC type of histology. This is not included in the LIRAD algorithm as so far, but LIRAD is a dynamic document and they keep changing it to make it better. Then there are some features on imaging which can suggest microvascular invasion. Microvascular invasion is before there is visible thrombus in the branch of the portal vein. And these features are if you have non-smooth margins. On a T2 weighted image, if you have very non-smooth margins which cannot be identified like a pencil sharp margin, and in the hepatobiliary phase, if you have a hypointensity in the periphery, these are features of microvascular invasion. May be worthwhile adding them to the report even though they do not form a part of the LIRAD nomenclature as of now. Here's an example of another non-rim type of arterial phase enhancement with thrombus in the portal vein. The thrombus is also extending into the IVC. You can see a big thrombus in the IVC going right up to the right atrial junction. Let's assign the LIRAD category to this lesion. There's a large lesion in the right lobe. Again, does not have a clear-cut margin to it. Shows non-rim type of heterogeneous enhancement in the liver. There is washout from the venous phase in the venous phase, which means it's become darker as compared to the background liver. Shows you diffusion restriction also. So this would be a tumor in vein because here the tumor has definitely gone into the portal vein, as well as the hepatic veins and into the IVC as well. So this is tumor in vein. This is an interesting patient that we saw just a couple of weeks ago. There are two lesions here. There is one lesion here, which is relatively T2 bright, and another lesion, which is relatively very mildly T2 bright. And the enhancement category was also very different. You have a lesion which shows you rim enhancement, suggesting mass-forming cholangiocarcinoma. You have another lesion which shows non-rim type of enhancement, and we were really foxed as to what this is. We biopsied the rim-enhancing lesion, and our possibility so far is that one of the lesions is an HCC and the other is a mass-forming cholangiocarcinoma, which is a very unusual situation, but it is described in literature less than 0.2 to 3%. You can get both tumors in the same liver, an HCC as well as a mass-forming cholangiocarcinoma. These are some ancillary features. Diffusion restriction means just a very bright signal on a high B-value image. Notice the presence of extrahepatic disease in this patient. There are multiple lymph nodes. This is the hepatocyte phase of this at 1 hour, again showing you that one of the lesions retains contrast, which is the feature of mass-forming cholangio, and the other does not. So these are two distinct lesions with two distinct morphologies and possibly two distinct histopathologies as well. This is the kind of structured report that we use. We assign a number to each observation, describe each observation in detail as per the LIRAD template. It just makes it simpler for the radiologist to remember what all he has to look for, and for the hepatologist to extract information from that report instead of a narrative prose type of a report. Then, of course, you could add the T staging as well. I'm going to skip some of these in the interest of time. Then you can have tumors like hepatocholangiocarcinoma. There was some discussion earlier during the day about this, where the same tumor, part of the tumor can show you features of mass-forming cholangio, and a part can show you features of HCC. This was one such patient that we saw in our institution. Moving away from cirrhosis and LIRAD, there are some key words in a radiology report. This is a large focal lesion involving segments 2, 3, and 4 of the liver. There is this peripheral nodular enhancement which matches the blood pool. Peripheral nodular enhancement which matches the blood pool, which shows centripetal progression towards the center of the lesion, and on the delayed phase shows you retention of contrast. These are features which tell you that you're dealing with a hemangioma, and the radiologist can be so sure that this really does not need any sampling, because sampling will only yield blood. It does not need aggressive treatment. This, of course, looks like a giant hemangioma and may need treatment for simply for the mass effect and the pressure symptoms that the patient may have. So the key words in the report would be the size, the location, nodular discontinuous enhancement with centripetal progression, delayed fill-in, and retention. This is a lesion which is barely visible on T1. On T2, it is hyperintense. You give gadolinium, there is some arterial phase enhancement. In the hepatocyte phase, it shows that the entire lesion is brighter than the background liver. This set of findings tells you that this is focal nodular hyperplasia, which contains functioning hepatocytes, and that is why it is taking up contrast in the 1 hour delayed phase. And here again, this lesion can be left alone. It is a no-touch lesion and it does not need sampling if the radiologist is certain. There is an emerging role for deep learning and machine learning in the field of reporting as well, not for the interpretation, but for converting your findings into a template. There are softwares which can do that you can just be reading your report like a prose paragraph form, and the software can convert it for you into a template. Thank you very much for your attention.
Thank you for a very simplified description of a very complex subject. The house is now open for comments and discussion. Yeah, may I ask a question, sir? Any role of MR in screening for HCC in a cirrhotic patient? Like we can have some.
So there is a modification of MR now. They are talking of abbreviated MR
Abbreviated,
protocols.
right.
So there is a lot of literature appearing from North America, where they are saying you could do a study in 10 minutes. You can tailor the, MR time on the MR table is precious. It's obviously has to be allocated to other patients as well. So, but you can do a abbreviated or what has been called an optimized MR protocol, but you need to have the luxury of having MR time available to you. And so far, at least in our country, it's very difficult to use MR. Many institutions use CT for screening because ultrasound has very low sensitivity. But so far, at least, there are very, very few institutions which would have the luxury of using MR. That MR is a very abbreviated MR where we just do T2 diffusion contrast. So it's a 10 or 12 minute protocol, but yes, there is a lot of literature to that effect.
Is LIRADS applicable only in a background cirrhosis? Non-cirrhotic, this LIRADS is not at all applicable?
Yes,
right?
in a non-cirrhotic background, in a liver which is not predisposed to developing HCC, LIRAD cannot be applied.
So one question, can we get some information about possible response to locoregional therapy? Like many times these tumors have small arterioportal shunts, and these are the lesions which don't do well after taste. So can be
So you're
some
saying before treatment,
before planning the treatment for the lesions.
so you're right, arterial portal shunt would be one such thing, but otherwise there aren't many features described which can predict. The work is being done in the field of radiomics, of course. There is a lot of literature appearing on texture analysis. Not so far for clinical use, but in the research domain, you can do texture analysis, and a lot of those parameters can predict whether the tumor will respond to treatment or not.
Thank you, sir.
But so far, not in clinical practice. Thank you.
Thank you, sir. Since we're short of time, we'll finish the session now. Thank you so much.
Thanks to chairpersons and speakers, sir, for such an enlightening session. With this, we move to our next session, session 9, that is on controversies in autoimmune liver disease. Let's freeze this moment. I would like to remind you all that we have inaugural ceremony at 7, followed by cultural program and gala dinner. We request you all to be present in the auditorium by 6:45 to witness this grand event. Thank you. I am deeply honored to invite on stage our chairpersons for session 9, Dr. Vandana Midha, Dr. Manav Vadhavan, Dr. Shalimar, and Dr. Uday Zacharya. I welcome you all on stage. Over to you, the chairpersons.
Okay, we have a very interesting session, and I have the privilege to invite Professor Gideon Hirschfeld to talk on should mycophenolate mofetil be the first-line therapy in autoimmune hepatitis. Please.
Well, thank you very much, and thank you very much for having me. So I've got 15 minutes to go through should MMF be the first-line treatment in autoimmune hepatitis. I'll just wait for the slide to disappear for the timer. So what I thought I'd do, because this is actually a very difficult topic, is give you some of the things that we do know about autoimmune hepatitis and some of the things that we know about MMF and why this question is relevant based on practice. These are my disclaimers. So what we're talking about is this. It is steroid-responsive, plasma cell-rich interface hepatitis. So I know that this appearance is not really autoimmune hepatitis, but it is essentially what you are treating in clinic. It's what you're seeing when your patient comes in with abnormal liver tests with jaundice. The challenge that we have, and the reason I'm presenting the data the way I am, is I want you to think about the limitations of the trials that we do in autoimmune hepatitis, because autoimmune hepatitis is not one disease. If it is not one disease in your clinical practice, it's not one disease even in clinical trials. And this makes the data that we have to manage our patients quite hard to interpret. So I want you to think that AIH is really this complex syndrome of different genetic factors, environmental factors, infectious agents we know, we don't know, drug exposures we know, we don't know, and individual risk factors. And this is why in clinic it's so heterogeneous, and it's even heterogeneous in clinical trials. The second thing I want you to take away from this talk is, again, ALT does not equal autoimmune hepatitis, just as, in fact, interface hepatitis does not equal autoimmune hepatitis. So again, this is a confounder when we look at the evidence for the treatments that we have, because in fact, for example, bile acids will drive up your ALT significantly. I just looked after a young woman in her first pregnancy who developed severe intrahepatic cholestasis of pregnancy due to a mutation in MDR3. She has an ALT of 500 up until the day of her delivery. I can drive down her bile acids down to normal with bezafibrate, but her ALT stays high. She neither has autoimmune hepatitis nor does she have a classical cholestasis. So, what are you trying to achieve in autoimmune hepatitis? This is our Canadian data. There's similar data. We know that the patients who have the best liver tests, the response at 6 and 12 months of ALT, have the best outcomes. We know that patients with persistent disease activity by liver enzymes are the patients who have reduced survival. In fact, what we also know is the starting dose of prednisone does not impact their outcome. So in fact, the more you give of prednisone does not actually change outcome. But what you should be thinking about is this is a lifelong disease. And the drugs that you choose at the beginning may be drugs that you'll be on forever. And we should be more cognizant as hepatologists of the treatment risks, toxoplasmosis, HPV, PJP pneumonia, etc., etc. And that's maybe why we should be changing our practice. But if we're going to change our practice in terms of new drugs like MMF, first of all, be clear where benefit exists. Sheila Sherlock, the famous hepatologist from the Royal Free, made people live longer with autoimmune hepatitis at a dose of prednisone 15 milligrams per day. That is evidence that prednisone makes you live longer. The response to treatment, this is beautiful data from the Mayo from 1972, more than 50 years ago, but it's slow. Your clinical response, your biochemical response may be quicker, but your histology takes 6 to 12 months longer to heal. So if a patient relapses at the beginning, that's only because you've rushed the treatment, because in fact the disease had not been treated fully. Azathioprine, the competitor for MMF, is also not a good treatment at the beginning to get disease control. Prednisone makes you live longer. Azathioprine, the probability of survival, again, data from more than 50 years ago, is not as good. That makes sense. It's a slow drug to work. Prednisone is a fire extinguisher. Azathioprine is a smoke detector. And in the systematic review of azathioprine for induction, we can see that it's not recommended as the inducing agent, and we can see that there's no difference in outcome between whether you use prednisone and prednisone plus azathioprine at the beginning. Now, the other thing that's really important if we are going to change to MMF, I'm not saying we should, is again to go back to real-world outcomes. This is data from Sheffield published from Dermot Gleeson in 2011. And if you look at the bottom of the slide, you can see that non-treatment with azathioprine is associated with worse outcomes. So as we make these decisions about new drugs, we should always remember what we already know about the current drugs. Prednisone makes you live longer. Not using azathioprine in second-line treatment is associated with worse outcomes. So we must not do anything that makes that worse. Finally, Phil Johnson went on to study HCC, but in fact his original papers when he was starting out were on azathioprine in autoimmune hepatitis. So this is his New England paper from 1995, demonstrating at 2 milligrams per kilogram, a dose that most of us wouldn't use because of the side effects, that azathioprine prevents relapse. Autoimmune hepatitis nearly always relapses if it's really autoimmune hepatitis, if it isn't overlap, if it isn't drugs, if it isn't delta hepatitis. So azathioprine prevents relapse. Now, we know that MMF has been used in transplant practice, our renal transplant colleagues, our liver transplant practices. Therefore, MMF as an alternative has been looked at increasingly. This is some of the data to start off with where MMF has been used has been in patients who didn't tolerate azathioprine. They become nauseated, you choose mercaptopurine and they're still nauseated, or they complain of thinning of their hair, or they just complain of abdominal discomfort. That's one group of patients who are getting MMF. And then the other group of patients was where azathioprine failed. Failure in azathioprine is a relative term because it really depends on how well you use it, whether you use drug metabolite monitoring, but in real practice, it still happens. And those were the two groups, and you can see the reasons why MMF was attractive to these authors because of the nausea, vomiting, because of pancreatitis, because of side effects. So this is then the data that led up to furthermore to the clinical trial that I'm going to talk about. And our Greek colleagues have driven the use of MMF in autoimmune hepatitis, Professor Dalakos. And this was his clinical experience from his program where he's been using a lot of MMF versus only a small amount of azathioprine. And you can see that MMS versus standard, that there was in his anecdotal real-world data, better response, there was less intolerance, and potentially maybe an opportunity to stop treatment, although that data is always very hard to interpret. So this then runs up into the clinical trial, an open-label randomized controlled trial of azathioprine versus MMF from the Netherlands, which is the reason for the question of the talk today. And this was to compare the biochemical efficacy and clinical tolerability of MMF as induction therapy for treatment-naive patients with autoimmune hepatitis. A very difficult study to do. This was open-label, and they had to recruit from across the country, and they had to have a lot of help from collaborating centers. The primary outcome was remission, if that's what you believe, that's at least one of the concepts from the clinical guidelines, which is a normal ALT and a normal IgG. They have 72 patients who underwent randomization. They have 70 patients assigned study medication. It's open label. And then you can see azathioprine plus prednisone, MMF plus prednisone, and then you can see what happened. In all clinical trials of autoimmune hepatitis, the starting dose of prednisone is very relevant because that may change the biochemical endpoint at 6 months. This is a high dose. I'll let you know that in Toronto, we look after 450 patients now with AIH, and it's growing. I use prednisone 20 for nearly everybody that I look after with autoimmune hepatitis, reserving high dose for other patients. MMF was then given essentially as Cellcept. This is not myfortic. That's also relevant because they're different. And azathioprine was given, but it was given in a standardized way. Or everyone was over 18. They had probable or definite AIH. You heard about the challenges of that from the histology discussion. And they had compatible histology. I think that's what the answer to the question from earlier is about how do you interpret histology. You use your brain and you look at the story and the biopsy and the patient and the blood tests. We excluded in this trial from the author's reports acute liver failure and variant diseases. The primary endpoint was the highest endpoint, biochemical remission. Then there were secondary endpoints about time to remission, proportional patients to non-response, safety. So here are the challenges of this clinical trial, because in the baseline, the ALT for the azathioprine patients is 541. The ALT for the MMF patients is 333. They are not balanced. They could not have balanced it. They weren't able to with the study design. But otherwise, these are patients with acute autoimmune hepatitis. They're not as sick as the patients you're about to hear from Professor Sarin. They don't have liver failure, but they're 99% type 1 autoimmune hepatitis with an inflammatory presentation. Here's the primary outcome and why you might like to consider MMF as an option. You can see that MMF in this clinical trial was associated with better response at 6 months, but per protocol, if the patient stayed on the protocol, there was no difference. Okay, biochemical remission was quicker in patients with MMF, but I remind you the ALT was 550 in the azathioprine patients and around 400 in the MMF patients. Here you can see the response to ALT and IgG from the two arms, and what you can really see is there's no difference between the two drugs. Non-response was the same between the two drugs, but again, complete biochemical response, normal ALT, AST, and IgG, was better in the MMF group. Other secondary outcomes were largely the same. Okay, the starting dose of prednisone, the cumulative dose of prednisone, the mean cumulative dose between the baseline and week 4. So there really weren't very many differences, otherwise. You can see that the azathioprine dose was relatively low. You can see that most patients got to the Cellcept dose that you would want. This is probably where the trial is strongest and most convincing. The drug was probably easier to use. I think that is fair, that is true. The azathioprine group were troubled with more nausea, more GI symptoms. The MMF group was really much better tolerated, and there were very few discontinuations. I think that is relevant to clinical practice, particularly non-expert clinical practice. So what were the take-home points from my perspective? It's definitely an alternative. Have I given the answer? Maybe. And it's better tolerated than azathioprine. There are lower adverse events. The strengths are, we now have data. This is the last trial evaluating induction of AIH was more than 10 years ago. This is randomized, it's multi-center, it's pragmatic. But we wrote an editorial on this paper. It's open label, so that really makes a difference. Okay, it's not randomized. The per protocol analysis did not demonstrate any difference, which in a sense biologically it's the same. Unequal distribution, higher baseline ALT, higher baseline MELD in the azathioprine group. They didn't try very hard with azathioprine. They really didn't try very hard. And you can't use this drug in young women who are potentially considering pregnancy. So it's a challenge. So where do we land up? This is a complex disease. Many, many causes, challenges in diagnosis, challenges in therapy, challenges in accessing specialist care, challenges in quality of life. But it is fair to say, and I am happy to conclude, that MMF would be a fair choice for use in induction for treatment of autoimmune hepatitis. Thank you.
For an excellent talk, I request you to join here. We move on to the second talk by Professor Sareen, Severe Acute Autoimmune Hepatitis, Corticosteroids versus Urgent Liver Transplant. Over to you, sir.
I'm very grateful to Dr. Duseja and INASL for inviting me, and it's a treat to listen to Gideon. And when the world expert tells you that it's a difficult, complicated disease, we have to accept it. And I'll try and add some more complexity to what it is like. I have no conflict. I'll try and briefly touch on the terminologies which I would like you to carefully understand. This is Tanaka's recent review. You have no pre-existing chronic liver disease, then you will call it acute autoimmune, acute severe autoimmune, or something presenting as ALF. If there is underlying chronic liver disease, you will call it exacerbation of AIH, or acute severe exacerbation of AIH, or AIH presenting as ALF. See that mild is not icteric always, moderate is icteric, severe you have coagulopathy, and here you have liver failure. However, there is overlap, and AIH presenting as ALF may have underlying CLD. We used to, when we were students, we were told AIH is always chronic. It's a chronic liver disease. But I am trying to tell you there is a spectrum which we have to accept and understand and diagnose. So what is the proportion of acute severe AIH? Of all the series, you can have 12%, 11% to 43% of all your patients of AIH. The definitions vary from less than 30 days to longer, but the commonest one that you will see that there is acute onset of symptoms, bilirubin is high, ALT is high, and no prior history. The proportion again as ALF or ACLF can be somewhere from 8% to 25%, depends on which part of the world you are, and several series from India as ACLF can be from 3% to about 9% or so in Japan. How do you approach such a patient? You have a patient who has abrupt onset first time of ALT, AST, which is more than 10 times and within 26 weeks as per the ASLD. So you will say no viral hep. You will also say no alcohol MASLD. You would then consider it can be AIH. And in history, you will also do a complete alcohol assessment and ANA, asthma, and IgG testing should be included in any abrupt elevation of transaminase. You will have to take a history of DILI, which can also present as autoimmune, and no response after withdrawal you will have to consider. Now comes the beauty of medicine. You have ANA negative and normal IgG, and this can be present in 1 out of 3 to 1 out of 5 patients of acute severe. So you have no clue except your clinical judgment. You then will have to consider to do a liver biopsy, which may give you typical findings or may give you atypical findings. So autoimmune severe disease is a spectrum. Let me show you some of this. This is AIH presenting as ALF. So now how can you have ALF with ascites? Yes, if the loss of parenchyma is more than 40%, it is acute portal hypertension and you will have ascites. You can see some massive necrosis here, and this is a patient, you can see most of the left lobe and most of the periphery is gone. So you can have ascites in AIH as ALF. Another acute severe AIH presenting here, massive necrosis, and you can see the CT scan, very differential perfusion of this. Let me show you some more AIH as ALF. Now here again this patient you will see that there is some tongue-like projection. I would have thought this could be as a patient with chronic disease because of the left lobe tongue, but it is again presenting as, and this is an explant, the patient had an explant liver. So ALF presentation can be in the patients of autoimmune hepatitis, so don't miss it. This again, just to show you AIH as acute or subacute hepatic failure, the whole of the central vein area is necrosed, portal tracts are now coalesced, and you have features, in the same, you have central vein, portal tracts, all of them. And this came in hepatology as a beautiful paper. I would request you to read it. Now comes the spectrum of chronic presenting as flare of autoimmune. And here you can see this is a chronic liver disease where you can have flare and you can have massive, and there are several 4 criteria. I'll not go into details of perivenular or no, and the interface you have already seen the debate. Here you can see again acute exacerbation of chronic hepatitis where you will have lymphoid follicles, lobular inflammation, and appearances of acute autoimmune hepatitis flare. So with this and the burden and the diagnosis, the topic given to me is whether you should give steroids, are they effective or not. So corticosteroids, you have heard the story starting from Mayo. And now, what are the predictors of response? You have a patient and you want to be sure, will it respond? So this beautiful study, the French cohort, 128 patients of acute severe autoimmune hepatitis. 115 were treated. Of them, 30 received liver transplant and 85 did not. You see that there was not much difference in those who died. But they developed a calculation based on these who received steroids called Surfasa score. They included grade 1 and 2 encephalopathy in 15%. The Surfasa score gives you like DILI, like Lil score, day 0 and day 4. Surfasa gives you day 0 and day 3. And 3 variables are important. Day 0 INR if it is high, day 3 reduction in bilirubin is less than 8%, or INR reduction is less than 0.1%. These 3 will make the Surfasa score at day 0 to day 3. There is only one predictor at day 0. Now using this, if you have given corticosteroids, can you be sure that my patient will be benefited or not? So this is the cutoff of minus 0.9. Let me show you this beautiful figure. So if you have a figure of 1 or minus 1, all those who have a Surfasa of less than 0.9, they had survival, liver transplant free survival. But if you go on this side, they will die. So less than minus 0.9 at day 3, those people have a survival advantage. You can see here. But but it looks too good. But therefore, what the paper is, but you have to test it. So this was tested in Japanese cohort, and they said Surfasa is not reliable, day 3 is not good, day 7 or day 20. So what they did was they took a group of patients, they gave steroids, those who got liver transplant or died, those who had insufficient response or partial responders or responders. Not a big group, but the study is beautiful. Those who are non-responder, their MELD never came down. Those who are partial responders, they responded by day 20 or 21. Those who were complete responders, they started responding by day 4. So what the message is, things like MELD or Surfasa, if it works by day 3 or 4, he will be a good responder. But it is not foolproof. Some patients you have to continue till day 21. Then there is a cohort from Asia, and this is by Lavkesh, and this is a huge study from Asian cohort, but they all had ACLF, means jaundice, ascites, and coagulopathy. 82 patients were taken in AIH ACLF. Those who responded to corticosteroids and those who did not respond, this survival was significantly different. Now, who responded or who did not? Those who had an advanced age, MELD above 27, those who had HE or fibrosis F3 or more. So, if you have a patient where these things are there, this patient is unlikely to respond. Then Sanchit did a study on whether Surfasa and the ARC score or some other features can be analyzed. So here is the group of patients that they looked into, and they found that the predictors of non-response in AIH ACLF is bilirubin, albumin, INR, ARC score, and MELD score. And they developed this beautiful ROC. So if you have only MELD, it may not be as reliable. If you have ARC, it may be quite reliable alone. But if you use ARC plus Surfasa, it probably might be best. Surfasa alone is still lower than the ARC score. And this is their analysis, Kaplan-Meier. They showed that patients who had more than less than 1.2 or more than 7 ARC score, they had the worst outcome. So if the ARC score is above 7 and the reduction, let me show you back what is 1.2 means. 1.2 will be something like here, and these people will die. So if your reduction is less than 0.1 minus 1.2 and ARC score is high, these patients will have poor survival. Now, steroid non-response in this recent paper also showed one interesting thing, that when have you started steroid? If a steroid is delayed in starting, these patients may have poor outcome. Now, you have decided my patient is not responding, and I'll show you some algorithm on timing and outcome. This is my algorithm. You have to improve upon it because I am not perfect in this. So a patient comes to you, if he has grade 3 or 4 HE LT, his INR is high, MELD is high, massive hepatic necrosis if you have been able to get a biopsy, is multi-organ failure or uncontrolled sepsis. If he is steroid eligible, I will give 40 to 60 or IV methylpred, and I will also see it is done immediately. HE grade 2 or less, INR is less than 2, MELD. So between 2 and 3 I have no solution. MELD is less than 24 based on our ARC data, and ARC is less than 7 if he is ACLF and no uncontrolled infection. I'll start steroids and I will assess day 3 and day 4 response. Surfasa has decreased by, as INR has decreased by or equal to 3, 0.3. Bilirubin has decreased. 8 was the cutoff. I have kept 10 to 15. MELD has decreased by 2 or more. And ARC Surfasa score you can apply. If this is true, I will continue steroids. Otherwise, I'll send it to LT. And jury is out on that. Does transplant help? DDLT is easy, but LDLT is a challenge. Why? Because the donor may also have autoimmune features, so donor screening may be a failure in LDLT. These are the LT outcomes. This is a recent data published in 25 now. 1 year and 5 year survivals are good, but you may have high rejection and recurrence. The ELTR registry European says good data, and UNOS registry also says, and 10-year survival can be 62%. The patterns of rejection, this is a beautiful paper by Satpathy, who has shown that the recurrence acute cellular rejection is highest compared to others, and also methylprednisolone will be required. The graft survival, if you have given IV steroids, is good. My carry home message: carefully assess for ALF, ACLF in AIH. So, if you have no virus, no alcohol, no drugs, it may be that you have severe acute ALF due to autoimmune features. Corticosteroids given eligible but give early. Prepare for LT simultaneously. Take day 3, day 4 as your day, and assess role of other drugs, plaques and others. Thank you for your kind attention.
Thank you, sir. Could I open the to the hall for questions from the audience?
Professor Gideon, if may I ask, you said MMF can be used as as a first-line drug. In which situations would you not like to consider, say, what Professor Sareen showed us regarding the acute severe autoimmune hepatitis? So, which patients do you say, I will not use MMF?
Well, I mean, first of all, my comment says that really I think biologically MMF and azathioprine are as good as each other in treating autoimmune hepatitis. I think that what MMF does is that it's a little bit easier to use and may just be a little bit more reliable and a little less fiddly, but it is more expensive and you can't use it in young women or a woman who want to still conceive, and that could be any woman under the age of 45. So you really should be very cautious. I think your question, however, dovetails into the different stages of autoimmune hepatitis. So really, what we're talking about is different settings. In the ambulatory setting, we're seeing this acute patient up until acute severe, and that's a whole range from minor liver tests all the way up to an INAR of 1.5. What Professor Saran was talking about really is the very, very, very sick patient. In the very, very sick patient, there's no need for you to even worry about MMF or azathioprine. What you're trying to do is save their life, and you'll decide that whether they're a transplant or prednisone. And if the prednisone works, then by all means come in. Traditionally, I don't start azathioprine until the bilirubin was less than 100, less than 5. I think, generally speaking, it would be the same with MMF. I wouldn't be under any rush in a sick person to be starting their second-line treatment. Fundamentally, just remember, prednisone is a fire extinguisher, azathioprine and MMF are smoke detectors. They are doing different things. The patients who are as sick as Professor Saran, it's a totally different set of decision-making.
Microphone 1, please.
Yeah, I'm Dr. Vrinder Singh from Punjab ILBS Mohali. Sir, regarding the azathioprine, I must have used in hundreds and hundreds of the patients with AIH. I never realized that they never dropped the azathioprine. See, the nausea and vomiting is not a feature. They tolerate very well.
Exactly. That was my point. My point was they didn't try very hard. So I think if you're an expert provider like you have a lot of patients, you get good at using azathioprine, you don't rush your patient, you split the dose, you teach the patient how to use it. But in the real world, many people looking after autoimmune hepatitis don't have as much experience as you. And in that situation, MMF is probably true. It's a little bit easier to use. But you're absolutely right the reason we wrote the editorial on that clinical trial was that because if people look after a lot of autoimmune hepatitis, they actually find azathioprine quite easy to use and they feel good. And that's why I concluded by saying it's a fair choice to use MMF, but I wouldn't conclude it is better.
Yeah, Dr. Sareen, here is a patient with the bilirubin of maybe around 3 or 4, and patient comes with the ascites, and there is underlying cirrhosis, autoimmune markers are there, the OTPT also is raised, and how much corticosteroid you will give to this patient?
This will be AILD, autoimmune liver disease. So he is like a burnt out cirrhosis who has ascites, and bilirubin is 3 or 4. If the enzymes are not very high, I would be very hesitant to give him steroids or something. I would do a biopsy, and if the biopsy shows there is activity, I may consider. Otherwise, he may be probably too late. Yes, if ascites rise, I might start him on low dose steroid, not on high dose steroids.
Even if the enzymes are in hundreds?
Oh yeah, if enzyme, then it is a flare. Then it is a flare, then it will be in a way close to ACLF. I'll do a biopsy, and I have a patient right now who was treated like granulomatous disease and he was given ATT in addition. And this patient has a typical 1100 to 1500 A and not drug induced. So we did a biopsy, confirmed it is autoimmune, steroids given, and dramatic response.
See, this is, one has to be very careful in such patients. Start antibiotic, not without antibiotic, and put them on not the 40 to 60 milligram of the corticosteroid.
Not high.
Give only 20, maybe you can see.
0.5 milligram.
Yeah. And then after that you can watch maybe on 3rd day or maybe 7th day if patient is tolerating and the bilirubin is coming down better, then you can increase the dose. So you have to go very, very slow.
Agreed.
Thank you. Professor Sareen, what's your comments on immunotherapy? Because we rescued few children with rituximab, and we think we avoided a transplant, but do you consider it in your practice?
Yeah, I did consider in 2018-19, I treated 2 patients with rituximab who were steroid refractory, and I messed up in both. And the patient were so sick after a single dose of rituximab, they could not even be transplanted, so we lost one, and second we rescued. Although there were a lot of reports that rituximab may be good, but I don't know. I don't have much. 2 patients, both I messed up.
So there are, I think, differences in the pediatric practice. We use much higher dose of steroids. You are saying 0.5, we go
No, for AILD.
Yeah.
For these patients, like the one I was talking who had a flare, I used 250 milligram for 3 days, like a pulse therapy, and the patient came down. His bilirubin was 9 or so, 10, and now it is 6. So,
no, like Gideon was saying that you use 20 milligrams
Yes, but
as
remember,
induction.
children tolerate things much better. So what
Okay.
what I'm trying to express is the fact that as hepatologists, we need to be much more mindful of the side effects of our drugs.
Yes, correct.
And AIH is incredibly heterogeneous, which is why it looks like you can, you've got this whole issue about the dose ranging of prednisone. In the chronic setting, the starting dose of prednisone does not change the outcomes for the patients. I agree that a child, has a much more potent barrier and a much more higher inflammatory burden. You may want to be in a rush. But remember, you're giving a high dose, but you're tapering very quickly because of the side effects on their bone and their growth. Okay. But as our patients get older and older, and the average age of autoimmune hepatitis is in the 50s and 60s, I think we should just be more mindful. You should never use rituximab in acute severe autoimmune hepatitis. I think that's probably crossing the line. Rituximab can be used in patients who failed second and third line treatments. Most of our success has been in that kind of grumbling patients where they are sick, but they're not as sick as this. I'm about to give someone rituximab who's just had a flare who's exactly as actually perfect description from Professor Sarin. She's cirrhotic. I withdrew the prednisone a little bit, and her bilirubin's gone up to 200, and the INR goes to 2. But she's had disease for 30 years. Her IgG's 60. I think she'll respond to rituximab. Okay, but you've got to choose carefully.
These are the patients we are talking.
Yes.
Otherwise, they go for a transplant,
I
as
think
you
when they're
described
that sick,
earlier.
I'm not going to try rituximab.
Yeah. Thank you.
Dr. Sareen, excellent talk as usual. I just wanted to ask that in acute phase, where it is presenting like acute viral hepatitis, they have ANA positivity. How do you assess these patients for whether to put them on steroids or not?
That is a very difficult. The group of indeterminate ALF or indeterminate ACLF, I think their majority are autoimmune flares, which we don't understand. And autoimmune flares can be even by somebody has hepatitis A, and hepatitis A stimulates your microbiota of the gut as a nude virus. So you can have double presentation, hepatitis A with severe autoimmune features. We cannot manage these patients. Even with liver transplant, they will die. So that's one group. So how do you assess those who are virus negative, DILI negative, or alcohol negative? I gave you an algorithm. We cannot do liver biopsy in everyone, and biopsy sometimes is non-descriptive. I would say keep the transplant ready. Meanwhile, you may try hydrocortisone or methylprednisolone, but just for 3 days in very severe disease. Otherwise, they are difficult patients. Maybe Gideon can.
I agree. Tread very carefully. Don't kill your patient of sepsis if that means they can't get a transplant.
Keep it. Yes.
Hi, Kalyan, Cleveland Clinic. Professor Gideon, patients who are kind of deemed as azathioprine failures, are you looking for achieving a 6TG level more than 220 before calling them failures?
So I think if you're a purist, then yes. I think if you have the ability, you have access to these testing, and your patient is very sort of adherent, then for sure azathioprine metabolites can be very helpful. In the real world that I live, my patients live too far away. I can't get the test. The result doesn't come back quickly enough. And so we're very, very selective in who we do the metabolites, only where we really want to see toxicity and a reason to switch. And we have a patient where we think that they're too young for MMF, and we think we can make the azathioprine actually do its job. I think for people who don't have big practices, it's very hard to be trying to teach them to be using this finesse use of azathioprine metabolite monitoring. It just doesn't, I think it's very hard in practice.
And the second question is, do you actually monitor the IgG levels and up-titrate immunosuppression to achieve histologic remission? I know biochemical remission is... No.
Well, okay. So we follow ALT and IgG. We do aim to get the ALT as low as possible and the IgG down as possible. The evidence that IgG is prognostic long-term is not there. IgG is good from a diagnostic perspective, but in fact, a lot of the data suggests that IgG is not actually prognostic. Okay, I treat the whole patient, and I really try and encourage people not to slavishly follow the target. You don't die of liver tests, but you do die of pneumonia, and you do die of lumbar spine fractures, and you do die of cancers. So I try and be as pragmatic as possible.
So last question,
Yeah,
please.
just a question. There was a recent publication on the use of infliximab in autoimmune hepatitis. I'd like to know what is the likely prospect of that being one of the tools.
Infliximab is a good drug, and I was amongst the first to use infliximab for severe alcohol-associated hepatitis, which I think is an autoimmune disease. I don't think it is just pure alcohol, it is alcohol plus autoimmune. And it worked well, but we got sepsis. And the French trial also said that inflixi can add sepsis. Now, in autoimmune hepatitis, using infliximab, and I have seen that trial, I have my reservations. I'm not too sure it would work that way, but we can ask the expert. My opinion is don't use it.
Yeah, I mean, we've used it only very occasionally. We prefer B-cell therapies. Rituximab would be our choice if we're going to use a biologic. I think infliximab is really a very powerful, expensive steroid, so I'm not surprised that there will be some response in some patients. But to Professor Saran's perspective, if they're very sick, in the original paper there was some viral illnesses, some reactivation of viruses. So I think you've got to be very, very careful with any of these biologics, but anti-TNF in particular.
Due to paucity of time, I think just a brief comment or a question, please.
So
The last one.
Yeah, we have a very difficult set of patients. Sometimes we have patients with ACLF who are being admitted to the critical care setup. So we know that most patients with severe acute AIH autoimmune profile may be positive, maybe only in 20 to 30% of these patients. So in such patients where a biopsy is not feasible, say, for example, even the autoimmune profile turns out to be negative, do we treat these patients with steroids on the suspicion of autoimmune? Or do we go for a plasma, or how should we manage such
We
patients?
want your opinion. What do you think we should do? Because Dr.
Well, I think it does
Omkar
depend,
is from our hospital, so
well, I
he
mean, once
knows.
they've got grade 3 encephalopathy, I wouldn't give steroids. I think in the earlier case, I think if you're in the right setting and you are vigilant, it is not unreasonable to give a steroid trial being empiric, because there will be some patients who respond. But the real message is you're seeing this patient twice a day. Okay, and you're making dynamic decisions, and you've got to know when to stop. And to the other point, you've covered them for sepsis, and you're vigilant for fungal infections. So I think there is a role, but it really is under a tight microscope.
One small question, and which might be helpful for all of us. Would you give azathioprine when the bilirubin level is above 3? You said 5 milligrams.
Yeah.
We all are scared, and as our understanding is, don't give AZA above 3.
Yeah, I mean, so in the chronic setting, I normally wait until about a bilirubin of 100, but I think it's reasonable to be cautious, and there's no rush to start azathioprine. So by all means,
AZA
just
we
wait.
can give.
Yeah.
AZA we can give with higher. We are
Yes.
using not AZA, sorry,
MMF, because of
we are
Trump, yes.
using.
Exactly.
But AZA, I think
Yeah,
little more
Dilly,
caution
I
for
agree.
high bilirubin. Okay, thank you.
I think that was a wonderful session, and with that, we'll bring this session to a close. Thank you, Professor Sareen and Professor Sri.